All right, anesthesia residents, welcome. We are about to do a super high-yield, board-focused review of the ASA Physical Status Classification System. What we're going to do here is take this topic and make it simple, easy to remember, and something you can actually use, both in your daily practice and, of course, on your exams. So let's jump right in. So, picture this. You're in the pre-op area. It's chaotic, right? You've got just a few minutes to size up a patient and then tell the entire surgical team what you found. And that's the big problem we need to solve. How do we get a quick, consistent, shared language to talk about a patient's overall health before a procedure? And this is where the ASA classification comes in. Now, listen up because this is a huge point, so don't forget it. The ASA class is not a measure of surgical risk. It's a grade of the patient's underlying health, their physiological piggy bank, if you will, before we even think about what surgery they're having. Okay. Let's dive into the nuts and bolts of the system. We're going to break down all 6 classes, and we're going to focus on the definitions and those classic examples that you absolutely have to know for your boards. So, ASA1 is as straightforward as it gets. It's your baseline, a totally healthy, non-smoking patient who barely drinks alcohol, if at all. There are no underlying issues, no organic, physiologic, or psychiatric problems. Think of that young, fit patient coming in for an elective ortho case. Easy peasy. Okay, now we're stepping up to ASAI2. With this class, we're introducing a mild systemic disease. Now, the big thing to remember here is that the condition is well controlled and doesn't really cause any major functional problems. This is your bucket for current smokers, patients with perfectly controlled high blood pressure or diabetes, or someone with a BMI between 30 and 40. Now, pay attention here, because the jump to ASA3 is a big one. We go from mild to severe systemic disease, and now it is causing some real functional limitations. This is where control is everything. That patient with diabetes or hypertension that's all over the place, that's an ASA3. Morbid obesity, a BMI of 40 or more, that also falls right here. And here's a classic board question for you. A patient with end-stage renal disease who's stable on their regular dialysis, that's an ASA3. Oh, and a history of a heart attack or stroke from more than 3 months ago? Yep, that's going to be an ASA3 too. With ASAIV, the key phrase you've got to burn into your brain is a constant threat to life. These patients are not stable. And look, here's that super important time distinction again. Remember that heart attack from more than 3 months ago was an ASAI3? Well, a recent one, less than 3 months ago, launches that patient right into ASAIV. That difference? That's pure gold for your exams. It's the same deal with kidney disease. A patient with ESRD who is not getting their dialysis is an ASAIV, which is a world away from the stable ASAI3 patient who is. ASAV, this one's pretty simple, but it's also really grim. This is a patient who is circling the drain. They are not expected to live without an immediate operation. We're talking about a ruptured aortic aneurysm, a massive trauma, a huge brain bleed, a true life or death situation. Basically, surgery is a Hail Mary. And last but not least, ASIV. This is a very, very specific category. It's used for one thing and one thing only, a declared brain-dead patient who is an organ donor. All right, so you think you've got the definitions down? Let's find out. We're going to do some rapid-fire board-style cases to see if you can put this knowledge into practice when it counts. Okay, case number 1. Take a second and read this. He says he has no medical problems, but look closely at his social history. So what are you thinking? If you said ASAII, you are spot on. And this case is perfect because it shows a really key point. Even though he doesn't have a formal diagnosis like hypertension, the fact that he smokes a pack a day and drinks every night, well, that counts as a mild systemic disease. It automatically bumps him out of that perfectly healthy ASAI1 category. All right, on to case number 2. The key phrases to zero in on here are end-stage renal disease and compliant with hemodialysis. So what's her class? Yup, this is your textbook ASA3. Her ESRD is definitely a severe systemic disease, no doubt about it. But, and this is the key, because she's stable on her regularly scheduled dialysis, it's not considered a constant threat to her life. That's what makes her a solid 3 and not a 4. Okay, last case. The clue here, the big one, is the timing of his MI. It was 9 months ago. So what's the right call? He's an ASA3. And why? It all comes back to that critical time-based rule we talked about. Because his heart attack was more than 3 months ago, we classify it as a severe systemic disease, but it's not an active, life-threatening problem right now. Now, if that MI had happened 2 months ago, he'd immediately jump to an ASA4. See the difference? Okay, so we've learned the rules, we've done some cases, but, the real world is never that clean. The definitions might seem black and white, but when you're actually on the floor applying them can get, well, a little subjective. This quote right here just nails it. The ASA system is a fantastic tool. We need it. But it's not always cut and dry. The thing is, studies have actually shown that you can have two different anesthesiologists look at the very same patient and come up with two different ASA classes. And if you need to see it to believe it, look at this chart. This is from a study in 2020 where they gave 15 different clinical cases to over 250 anesthesiologists. And the takeaway here is, well, it's kind of mind-blowing. In not one single case, not one, did everybody agree on the ASA class. There was never 100% consensus. So the study put a number on it and found only a moderate degree of agreement. What does that really mean for you? It means that while the ASA classification gives us a great framework, your clinical judgment and how you interpret the patient's story play a huge role, especially when you're trying to decide between those borderline ASA 2 and 3 cases. Okay, let's bring it all home. I want to make sure you walk away from this ready for your next shift and definitely ready for your exams. So let's boil everything we've talked about down to the absolute must-know take-home points. First, and I can't say this enough, ASA is about the patient's health, not the surgical risk. Second, you have to be rock solid on the difference between mild disease for ASA 2 and severe disease for ASA 3. Third, whether a disease is controlled or out of control is often the deciding factor. Fourth, you just have to memorize this time cutoff. An MI or CVA over 3 months ago is a 3. Less than 3 months, it's a 4. And finally, just remember that in the real world, there's always going to be a little bit of wiggle room and subjectivity. So I want to leave you with a question to think about as you go about your day. We know the ASA system is a communication tool, and we know there's some variability in how people use it. So what can you do in your own practice to make your assessments more consistent and more clear for everyone on the team? It's something we should all be thinking about. Thanks for tuning in.